All right, well, good afternoon. Thank you all so much for joining us in today's discussion around quality supportive housing and kind of what that looks like. We're going to have an opportunity to describe that and go into some depth about some examples about what that looks like around what is quality supportive housing. So would love if we could pull up our slide deck and we will get started. All right, so we're here at the Nevada Housing Conference 2021 in person. Are y'all excited about that? I'm super excited to be in person. And to have an opportunity to talk about affordable housing is important. It's definitely a need in our community, in our state, across the country, right? We need more affordable housing, period. But this subject is so important to be having in the context of folks that need affordable housing, that affordable unit that we know keeps people stably housed. And then there's folks that also need some services that, in order to stay housed, they need those resources to maintain their housing. And so today's session, we're going to describe and define it and really talk about what that means to quality standards. So next slide, please. So for those of you who may not know of the organization that my coworker and I work for, CSH is also known as the Corporation for Supportive Housing. And we are a national nonprofit, actually, that has offices throughout the country. But for the past 30 years, we have been a partner in communities, really helping to figure out how to create a healthy pipeline of supportive housing. And we do this work by various different lines of our business, from training and capacity building. We know we need a workforce that knows how to do supportive housing well, from our service providers, our developers, our funders. We want to make sure people understand what that means, so we educate. And we also do lending. We're a community development finance entity, so we also are providing those project initiation loans to kind of help get projects off the ground. We are also a policy advocate, a fierce advocate to change the policies that create barriers to keep people out. We work to kind of address those as well. And we are a consulting technical assistance firm. And so our team, we work in community. The fact that I'm a native of Nevada, it's important for me to see solutions in my community. And so being able to bring those best practices here it's personal for me too. So on the next slide, just quickly, again, Brooke Page, I'm the director for the Southwest, which includes Nevada, Arizona, Texas, Utah, New Mexico. So we've got a very large geography. But I'm a Nevada native. I actually started my social service career in this building at Nevada Partners and the Culinary Academy. And so working in this community and really helping to address social change is really what my passion area is. And I'll turn it over to Ari to introduce herself.
Told this mic is better. Okay, hi. Good afternoon, everyone. My name is Ariana Saunders, and I am a senior program manager, also with Brooke. I'm part of the Southwest team. I'm really happy to be here. I am a local Nevadan. I'm not a native, but I've been here for a couple of years, and I'm really passionate too because this is my community, and so I want to see my community members thrive. So very happy to be here with you all.
Great, thank you. All right, next slide, please. So we are, and we're going to go to the next slide. We're not going to do the poll, and we want to make sure that we recognize we've got a robust online presence that are joining us today too. So thank you so much for our online folks that are gathering. And so we wanted to have the conversation about why supportive housing, and we talk about this showing data to help us describe the need. And so we know that according to CSH, we have a national supportive housing specific needs assessment that we do for all the states in the union, but specifically in Nevada, we know that there are 8,000 people that need this intervention called supportive housing. These folks are made up of our older adult population. There are transition age youth that make up this population. There are people that are exiting our justice systems that actually make up the highest population that need this intervention. There's about 2,500 people that are impacted by the justice system that really don't have access to permanent housing solutions. And so that's the data. We also know that in Nevada, and also in Southern Nevada specifically, we've seen an 11% increase in the rental market and the cost of rental prices from 2020 to 2021. And so we know that there's just shy of 5,000 available units in Southern Nevada. When the point in time count that was done earlier this year, there was 5,083 people experiencing homelessness. So if we only have 5,000 units available now, just imagine, that's the private rental market. Imagine what our homeless population and people that are experiencing some significant barriers have to compete with in our private rental market. So keep in mind the data and why this conversation is so important. Next slide. So, in addition to the need, we also talk about the importance of understanding disparities, specifically even racial disparities that impact our communities, right? When we see an increase in homelessness, it's likely resulting from systemic policies and practices and just issues around our structure and our systems. And so we really want to make sure that we understand the racial disparities that exist in community. And on the next slide, you'll notice that we have this slide represents the racial disparities in Nevada. We have a tool that we developed called the Racial Disparities, the Disproportionality Index, where we literally evaluate if a particular population is overrepresented in a system. And the data here that you'll see in the blue, the bars that are the highest, is Black people in Nevada are 5 times more likely to be involved in the justice system, in our homeless system, in our child welfare system. And so these perpetual disparities are impacting certain communities more than others. And so it's important that we recognize the data and what it's telling us. Also, our American Native, Alaskan Native population and our Hispanic Latinx population are also overrepresented. And a lot of times our Latin population, the data isn't as clean as it should be because a lot of folks don't participate in the systems in which this data comes from. So just recognize that the source of the data also may have some challenges as well. Next slide, please. So we have this story of data. It tells us a story, we can see it, but it also is important that we recognize that supportive housing can be a solution, and a solution that we see across the country to really support people that need this level of intervention. So what is supportive housing? So we talked about affordability. We all hopefully, when we think about affordability, we think about the fact that we don't want anybody really to have to pay more than 30% of their income on any household expenses, right? There's folks that don't have any income at all because they may not have access to getting employment or getting access to financial resources, right? So what kind of housing is available for that population? And so we recognize that we need an affordable place for people to live, but we also need services for folks that may need some assistance with getting access to employment, or maybe if somebody has, some varying degrees of mental health or substance use disorder that really needs some support getting access to treatment, they need a place to stay to get stabilized so they can work on those challenges. And so supportive housing provides this affordable place for people to live and those services to wrap them with, where the services are flexible, where they're voluntary, and where they meet the individual needs of the tenant. So we're not talking about a cookie cutter approach where we're expecting to fit one size fits all, but we really are thinking about the person that we're serving and meeting them where they are. Next slide, please. And so here is the person-centered importance of supportive housing. And so we recognize that there's various different populations that could benefit from a supportive housing resource. And again, we talked about the need earlier in Nevada. And so we know that chronic homelessness is something that we definitely want to get in front of in our community, right? When we talk about chronic homelessness, we're talking about people that have been on the streets for a long period of time, 12 months or more, and they also have a disabling condition. And so those folks really need to be in a place where they can stabilize. We're talking about, again, people that are exiting our institutional stays. You know, that there's people with intellectual disabilities that can't exit nursing home facilities or even an emergency room setting because they don't have a stable place to go, and not having an infrastructure where we can have a throughput for people to be stabilized is a challenge, right? So thinking about those emergency exits. Also the folks that do have intellectual disabilities, you know, if somebody has an older parent that's aging and they, you know, maybe have been living with this older adult parent and heaven forbid that parent passes away, what are our options for folks that have an intellectual disability and need a stable option? Again, folks with chronic health conditions, our aging population. We are, you know, a lot of retired folks live in our community, right? What are the infrastructures that we have in place for folks that are on fixed income and may have some chronic health conditions as well, onset dementia or diabetes? How can we support those folks to live the rest of their days with dignity and respect in a permanent home? And so these are the faces and just the experiences that folks with complex challenges need a supportive housing option that we want to really educate you all about today and figure out how we can create more of these options in our state. Next slide, please. And so we are here also to talk about quality. We emphasize quality at CSH because we have a dimensions of quality and supportive housing. If you can go back to the last slide, please. That standard helps us really set a bar for what we really understand works. And we have set this bar because for 30 years, we've been working in community, rural communities, urban core, our suburban communities, and really talking with people about how they've stayed housed for years. What was the secret sauce that kept somebody that was chronically homeless, that, you know, to be able to get employment and thrive in their home? What were those core ingredients and what did they look like? And so the things that we have found that make up a quality supportive housing project that differentiates between, you know, maybe just a project that is doing supportive housing, they're housing folks, but what does that quality bar really look like? And so we find that it's when housing is in safe neighborhoods, when we're not putting people with a substance use disorder back into a harming environment that triggers them with their substance use. If they're trying to be in recovery, we're putting them in a place where they can recover, right? And then that safe neighborhood has access to transportation that allows them to come and go and, you know, to their place of worship, to a healthy grocery store, and they're a part of a community. They have access to employment opportunities. Folks may want to work, and so getting them access to the services, the vocational training, and the resources, you know, they want to be in a place where they can, you know, access employment and services and shopping. Another key ingredient of quality supportive housing is tenants having a lease. No one should have to feel othered in any situation, right? And so somebody in supportive housing shouldn't be treated any differently than in any other unit in a development. And so the key ingredient of having a lease that has expectations and laws, we've got tenant landlord laws and experts that recognize, you know, if somebody does not honor this lease, then there's consequences, right? And so we emphasize the importance of a lease and the importance of not having required service provisions like drug treatment or mental health medication management. Those things absolutely should never be in a lease. And that's something that happens on the services side if somebody chooses to. And so the next one, the importance of voluntary services, is another key ingredient where the services are voluntary for a tenant. Everyone should have agency and feel the autonomy to want to go out and, get treatment if they feel like they're ready. And that stages of change is really important. And so what we talk about in supportive housing is, services are voluntary for the tenant when they're ready, but it is absolutely not voluntary for the service provider that's working for that in that program. And so we train our service providers to engage with our tenants in a way that's meaningful, that's building relationships, that's building, a sense of importance for this person to want to change. And so that relationship is, really, really important in that voluntary services model. And then lastly, the housing and its tenants are good for the neighborhood. We want developments that are going to be a beautiful asset for community, a place where people want to go and want to maintain that asset for the long haul. So we got to make sure that the funding is there to keep it there for the long haul, not only the operating dollars to keep it affordable, but also the service dollars to keep the services there for the folks that need it. So that's quality. As far as we define it, there's a lot of other things in the dimensions, but those are kind of the highlights. Next slide, please. And so we talk about supportive housing models, and I got to give a shout out to Clark County Social Service, or former social service employees. And we do a lot of work in the need in communities to really figure out how do we solve the issue of homelessness? How do we really work to address the need in our community? And a lot of our service providers in our state spend a lot of time working with our private market landlords, who are extremely important partners in this work. And so we recognize that scattered site is an option for us to help address the housing need and the housing shortage. But again, we've got 5,000 available units here in Southern Nevada. So we know that resource is very limiting. And so considering that, we've got to think about other lanes and other options to address the need in our community. And so other models that are utilized in other communities can be single site supportive housing, where there's a dedicated development that's created where folks may be 100% dedicated for supportive housing, or it could be a mixed income, mixed tenancy, where you might have 25% of those units that are dedicated for supportive housing, and the rest of the development is market rate units, right? But nobody would ever know where those 25 units are. Those folks don't sign a different kind of lease. But there's some nuances there that we'll talk a little bit about. So we've got this integrated model, we've got this built single site model, or we've got the scatter site model, which is what I think many of us are probably accustomed to in Nevada. Next slide, please. So the single site strategy. So there's advantages for having a single site where we can have one place where our tenants live, especially if we've got dedicated services for that certain target population. We've got permanently expands our housing stock. And so this is really important to our continuum of care folks that recognize the importance of having our housing inventory, where we've got more units now that are dedicated to taking people off of our coordinated entry wait list, and we can put them into a home, because now we've increased our stock by adding these units to our inventory. So that's an advantage. Ongoing control of the operation and the maintenance of the building, right? We have more control. We can make sure that if we're going to have a tenant selection plan that's going to allow for a certain population to live here, we can manage that, right? But when we're in the private market, and individual landlords, we don't have as much control and autonomy. And so recognizing the benefits of having that, centralized control. Also, units are affordable and on a long-term basis, right? We want to keep that unit affordable. And so we're going to do what we have to do as a single site project to make sure folks can stay here for the long haul. If we need to, go out and fundraise or figure out our operating subsidy, creatively, but we're not going to increase the rent on folks, because we know we need to maintain that affordability. And then units, the building and the units can be designed to meet the needs of the tenant. And what I really love about this is we just actually got an experience in Denver where there's an apartment complex called the Saunders Apartments. And this particular development was created with a trauma-informed design feature. And they are seeing remarkable results. If you have a chance to look at the social impact bond in Denver, I mean, it's just phenomenal that they took the highest frequent utilizers in Denver that were cycling in and out of the jails, emergency rooms, and they placed them in the Sanderson apartments, which is a gorgeous design. They designed it to where the hallways are larger, where the unit has a throughput. The person that lives there can see in and out of their unit from their bedroom, because they recognize the importance of just having a space for somebody that might have some triggering experiences that they want to feel safe. They designed it to keep, keeping that tenant in mind. But this project, after 5 years, saw a 98% retention rate from folks that were experiencing chronic homelessness and cycling in and out of jails and hospitals. And so just knowing that these folks had a beautiful place to live, in a place where they felt safe, in a trauma-informed building, it just has some really great ingredients to it. So again, thinking about how can we design a development that can meet the needs of our tenants. And then efficient access to on-site services. So this is always a benefit for our service provider folks that don't have to travel to multiple different locations throughout the community. They have one place where they can probably set up an office, meet with their tenants, provide that service on site, build a relationship with that property manager and the community to really understand the importance of just relationship building when we've got everybody in one location. Next slide, please. And thank you for those that are chatting in. I see the chat, Elaine, and so let me know if anything comes up that we need to address. And so assessing a built single site strategy. So some of the challenges with this, and we want to be transparent about challenges too, because everything's not always rosy, right? But we're going to tackle our challenges. So there could be a lengthy period before the units are available. Right. And so this is reality. If we're going to do a brand new project, we're probably about 2 to 3 years out before that lease up occurs. But, recognizing that when that happens, just imagine the benefit of when that does occur. It requires significant upfront funding and technical expertise, right, to get that development off the ground. Coalescing our relationships with different partners early on, our architects and developers and service providers, really to create this development. And so, thinking through those challenges is really important. And it's expensive, period. It is. It's expensive, but the cost avoidance of folks cycling in and out of our emergency rooms and taxing the system of just kind of the challenges that folks can community is actually twice as much expensive than if we put them into a stable environment. So really thinking through our cost benefit, our values as a community, our values to really understand what is the best option for folks and how do we kind of transition those costs into what works. And then the community may oppose the project and its intended site. And so NIMBYism, or not in my backyard, which I know yes in my backyard kind of kicked us off at this conference, but we recognize that that's the thing, and we can't change everybody's hearts and minds because we've got environmentalists that do not want any development, period, right? We've got folks that are just against anything. And so that's not our job to change hearts and minds for every single person, but, tackling those, figuring out, how to do that is going to be a challenge that we need to address. But then tenant choice, so one site, one place for folks to choose is not the ideal. We want folks to have a choice that they can live in different areas in a community is ideal, right? And so thinking through what does that choice look like that we still want to give people choice. Okay, next slide, please. And so the leasing scatter site strategy. So the advantages of the leasing. So again, we do scatter site. Again, that relationship with our private market landlords. Again, that saves time. It tends to be the quick thing that we do because we can do it quickly. Just go out, let's build some relationships. I know somebody that knows somebody that's got a unit maybe. And so we find that it can be more cost effective because we don't have to develop. We don't have to think about all of the costs associated with a new building. Leveraging our property owners, our management, maintenance, infrastructure, expertise. Our landlords are so important to our community. Bringing them in as partners is really a good thing. Property owners have access to operating subsidies, right? So, a landlord that may have access to a project-based voucher or housing choice voucher, that's good for their business. And it's something that then they know that they have a guaranteed rent subsidy. And then opportunity for collaboration on marketing and tenant selection. And so, we can justify the fact that you don't need to market your units anymore. We've got a ready list of folks on our wait list that will get you somebody right away, right? So we know the pitches, we know how to engage our landlords. Next slide, please. So some of the disadvantages to this scatter site model is, again, it's not adding to our permanent housing stock. So we got this subsidy that we might be able to help somebody with their rent, but we don't necessarily have that unit that's dedicated to the work. We also, the expertise or, we are in a tight rental market in Nevada, period. And so knowing that we're up against 5,000 units in Southern Nevada, need to get that number for the rurals in Northern Nevada. But, we're competing with folks that don't have necessarily the presented barriers of prior evictions or, may not have the justice involvement. And so how can we work with our tenants that we know need housing in order to get them housed? So that tight market is a challenge. And then convincing our private owners on the merits of supportive housing, that takes some effort, right? We got to change hearts and minds to our landlords to want to work with us. And then the lack of operating control over the property, it's the landlord. They may not want to fix the issue, the leak or whatever that issue is. And then the cost inefficiencies for scatter site management and maintenance. Okay, next slide, please. I'm trying to rush through this so we can we got so much great stuff we want to get to you all today. The next thing is our tenancy, the mixed income strategy. So again, similar to our single site, there's a lot of the same benefits because again, we've got a single site place with now multiple different tenants that live in that building. And so there's going to be some very similarities to that first one. So we're going to go to the next slide, please. And just a couple of challenges with the mixed tenancy is, lengthy period between units will be available. So we, just waiting for the units to come online whenever that development finishes, requires significant upfront funding, again, the expense, but then also the choice, again, similar to the first one. So next slide, please. Okay, so we talked a lot about the different types of models, and we talked about what supportive housing is. I'm going to end my segment with just talking about, lastly, why we know this works, and why I personally went to CSH to kind of understand how other communities have been doing this, and seeing the remarkable results that when we do supportive housing to quality, people stay housed. It's been demonstrated. The report that just came out in July showed people with high acuity, very difficult to serve populations, they stay housed. People are satisfied when they have a building and a development that they want to live in that has a beautiful design that meets their personal needs. So they're satisfied with that. They're satisfied with their services. If it's tenant-centered and people are providing them the services that they need, that their family needs to stay housed. People increase their income and the benefits that they're entitled to because they've got services that are helping them get access to those resources. Tenants improve their physical and their mental health. When we stabilize folks in a home, they're not worried about where they're going to eat. They're not worried about the challenges that the streets may bring if they're unhoused. Now they can finally focus on their physical health and going to the primary care instead of the emergency room. And they're not cycling in and out of our high cost systems. And also tenants have social and community connections. And some of the best supportive housing projects that I've toured, it's the tenants that are running the place. I mean, they've got their tenant advisory committees. They've got great events that they're putting on. They have, certain mutual respect that people aren't going to come in and destroy their development or their beautiful home because that's where they live, because they've created this sense of community. And we know that that's important for populations like our seniors that might be experiencing isolation when they live on their own. And so, just kind of thinking about these things is important when we talk about the quality of supportive housing. So I'll transition to Ariana to talk to us a little bit about what does the service models look like.
Excellent. Thank you, Brooke, so much for laying that foundation and kind of making sure we're all on the same page when we are talking about supportive housing. If you can go to the next slide, please. little transition. Okay. So now I'm going to talk to you, like, what does that look like? What are some models? What are some options that we have in terms of being able to insert those quality supportive services within supportive housing? There's a couple different models. There's evidence, there's research that back these. And so we really want to just take the time to educate you on those so we can take advantage of some resources that are coming into our community to either insert those or develop those to fidelity within our own communities in Nevada, or, you know, being able to take advantage of those to see how we can get as close to those gold standards to make sure that we're serving folks that really need these services. Okay, to the next slide, please. So the first thing we want to consider is really thinking about what should this model look like. There are a couple of things that really come into play, and you're going to hear this over and over again when we talk about supportive housing, and Brooke said it too, is it really starts with the tenant first, right? As in, if with anything else, that person-centered, client-centered planning and approach to it really starts there. And so it really means you need to understand what your tenant or your potential tenant population looks like. Will help you then identify what are the best practices, what is the evidence out there that shows us the services or the type of model that can best serve that tenant population. And that even goes into even helping us understand what that model should look like, as Brooke just talked about. Is it single site? Is it integrated? Is it a scattered site? You know, we really want to encourage more and more communities to step back from this old kind of way of thinking of operating from this point of scarcity, because we usually don't have enough services to support, or don't have enough funding to support these services. But if we're really talking and we really want to see success, we have to start with the tenant, understand what they need, and design programs and staffing models around that to really see these outcomes that Brooke just shared for us to accomplish with our tenants. So that's going to be really important as well. And then last but not least, we also have to recognize with the YIMBYism that we're striving for, we really need to make sure that we can articulate that we're meeting the community needs. So as Brooke said, we have a high need for transition age youth. We have a high need for folks that are exiting the jail system. We want to be able to articulate and prove that the model that we've chosen, the staffing pattern and the services that we're going to deliver within supportive housing is going to adequately meet that need, and that as community members in general, we will see a benefit from that, because we'll see less of our fellow neighbors and folks experiencing homelessness, cycling out of systems, and overall reducing the cost of utilizing those systems. Okay, next slide, please. And regardless of what the population is, we really also need to make sure that there's a couple things that we need to consider that we know work really well when delivering services in supportive housing or supporting folks so they can maintain their housing. Part of that is really making sure that we're coordinating those services. This is one of our huge dimensions of quality when we look at that, because we really know that people succeed when they feel like they're part of a community, but also we're treating the whole person. So recognizing their physical health, their behavioral health, their employment needs, being able to really make sure that we coordinate with other providers that are doing that. One thing that we know about successful supportive housing providers is we don't need to offer all of those services directly ourselves. It's really that coordination and integrating within the community is where we see people thrive within their own units or within their own communities. And we also need to do this work with cultural humility, recognizing, as Brooke shared, some of the disparities that are in our potential tenant populations, or those folks that are experiencing homelessness or cycling in and out of our justice system or our behavioral health system. We need to make sure that we're approaching that and recognizing individual differences, people's values and how they value help or how they seek help and what they think treatment should look like for them. We have to recognize that as well. It's really key to infusing that within your service delivery design and approach, because that's where you're going to see the most success. Again, it's literally meeting these people where they are and being able to provide the services that are going to best support them so they can be successful in their placements or in their own units. And last but not least, we really also want to make sure we're utilizing these evidence-based practices. And I'm going to talk a little bit about a couple models that we know really work and seen a lot of success in supportive housing, but that also speaks to being able to make sure staff that are in supportive services that really know what these evidence-based practice models are. One of them is trauma-informed care, recognizing, experiencing homelessness in of itself is a traumatic event and leads to many, many traumas within that. Right? But there's also other things that folks have experienced that we may never know about, but being trauma informed means you're recognizing that and trying to reduce the chances of them being re-traumatized. And so it's really coming with that compassion, starting from what happened to you instead of what's wrong with you is really what we want people to start with. And that's where we see the most success in supporting folks, especially those that are struggling with serious mental illness, chronic health disease, all of those things that we know people in our community need support and help in terms of treating. Okay, next slide, please. So a couple things that we know that have to be infused within the supportive housing services or service model that we know will lead to these outcomes that Brooke said, and many, many more, is really about really understanding that, you know, part of it is this continuous quality improvement process that we always have to look at our services to ensure that we really are meeting the needs of our tenants and we're seeking and achieving those outcomes that we're striving for. And that really, you know, is part of that is making sure you have a diverse staff that understand the tenant needs, that have a diverse background, diverse experience and skills and talents that come to play. And so we'll talk about some models that really are intentional about that. We also want to make sure that caseload sizes are manageable. Folks that really need a lot of services and intensive support, you need, for a successful case manager or person that is anyone that's supporting that person, they need to have the ability to give them that customized support. And so making sure that caseload sizes meet the needs of that tenant population is going to be really crucial. Again, I'll talk about what that looks like for a couple of the models that we're covering today. We also want to make sure that we ensure that staff has time to really do the work. You know, a lot of this is going to be doing work in community, whether it's at a single site or if it's scattered site, but it also is a lot of work that people need to come back to the office and document. If it's not in the system, it didn't exist, right? And so making sure that folks have that ability to do that and really making sure your staffing pattern provides that ability, and the way that you staff up your supportive housing providers is going to be key. And then also really making sure, again, we want that evidence. There's a lot of research out there that shows what type of services, what type of models work, and which populations they work for best. We really want to make sure that we're matching that and continuously finding ways to infuse that in our services. That includes motivational interviewing, like I said, trauma-informed care, assertive engagement. Services are voluntary, but they're not voluntary on the service provider side, right? So the tenant has a choice on what services they want. The onus is on the service provider to really get to know that tenant, engage them in a way that they can understand what they need, and motivate them to seek those services and match those services with the person's needs. Okay, next slide, please. And one key piece of this that we really like to drive home, as I talked about the best practices, the need for cultural humility, trauma-informed care, is really recognizing the strengths and the value that having somebody on your staff or a dedicated position of somebody who has lived experience. I can speak about this all day, but I won't. But it really brings a value, especially when we look at disparities. Not only do people with lived experience bring that knowledge and that expertise in terms of how to navigate the system, what it looks like to experience homelessness and then enter your new unit, what it feels like to never have ever had your own space, and how do you get accustomed to that. People with lived experience can do that, but not only can they do that, they can also offer hope to the individuals that are in these programs. Because I'm now talking to somebody directly across from me who I know has experienced homelessness. They know what it's like to have this trauma. They know what it's like to struggle. And so being able to do that and being able to offer that sense of hope and see somebody succeed and thrive and even be working for a program that they once received services from. I don't know any other way to offer that type of hope for folks when we know that people who've experienced homelessness are struggling with mental illness, chronic health challenges. That's what they need most in order to succeed and thrive, is they have to believe in their own recovery. They have to believe that they can actually thrive and succeed. When you cycle in and out of systems, it can really, that belief and that hope can really get beaten out of you. Not literally, figuratively. So being able to have a person with lived experience who brings that unique knowledge and their own skills and talents to the program is really where we've seen a lot of folks thrive and succeed. And it is special to note too that these services are absolutely billable by Medicaid and other funding sources, right? More and more people are seeing the value of peer support specialists or hiring people with lived experience. So it is absolutely a position, a dedicated position that can get funded and supported regardless of your funding source. Okay, next slide, please. And so before I go into the models and talk about some very specific models that have a lot of evidence to support this, I just want to recognize that there's a couple different ways that case management or support services can be offered within a program, regardless if it's scattered site or mixed. And one is, they can partnership with it. Like I said, we don't have to do all the services ourselves. We can partner with care coordinators through managed care. We can partner with therapists and other folks that can also provide support to that individual, or we can do those services directly. And I'll talk about some models that have that built in, where behavioral health therapy, clinical support is provided directly to those folks. We can also make sure that we develop strong brokered or really streamlined relationships with those providers in the community that offer those services, to really ensure that it's a warm handoff, it's a smooth transition. Once the case managers identified the person's need, they're not just giving them a slip of paper and saying, go forth and conquer. They're really making sure that that person has access, equitable, quick access to get some of those services that they need. And so there's a couple different ways you can do all three, or you can really focus on one or the other. Again, thinking about the tenant population, your resources, and your overall model is really going to help dictate what makes sense and what's going to be most successful for that. Okay, next slide, please. And as we said, all of this starts with the tenant. And so on the next slide, I think, one more slide. Thank you, sir. I think you got to go back. Yeah, thank you. It starts with the tenant. And so if you can see on this graphic, that's who we have in the middle. Again, it starts there. And then what we do is we build layers of services, again, treating the whole person to make sure that they're receiving the services they need to thrive within their unit and achieve whatever success is and whatever success looks like for them. As Brooke said, for some folks, it just means being stably housed and being able to wake up every day and enjoy the security and safety of that. For other folks, they can move on to get jobs and become peer specialists or mentors or jobs that we don't even realize that we're constantly engaging folks in our own community. And so really that starts with making sure we understand them. That second layer is that housing specialist or case manager, whatever that role is, but there needs to be somebody that's really focused. Their primary job is, how do I keep this person housed? So making sure that the person has all the skill sets they need, like I said, the services they need, the support they need to make sure they're housed. Is it managing their money? Is it learning or relearning daily living skills such as hygiene, how to cook for themselves, how to even shop for themselves? All these things that people either never learned or forgot because they've experienced homelessness or cycling out of systems for so long. And then that next layer is what the housing specialist does, is they make those connections to those services. Employment specialists. Is it somebody that's going to help them learn new parenting skills? Is it somebody that can help them treat their substance use disorder or find out the best services that they can treat? Maybe it's connecting them to a 12-step program. Whatever that service is and whatever that looks like, that's how we're going to help that person also maintain that housing. And then that last layer is really leaning on those managed care, those other supports that are in the community that we know will not only help fund some of these services, but also can make sure that that person's getting all of their medical and physical needs met so they can also succeed and thrive in their community. That serves a big role in terms of that care coordination. That's really, really important for folks that are living in supportive housing and making sure that they can also thrive. I don't know the exact data, but a significant amount of folks that are experiencing homelessness often qualify for Medicaid. And so being able to take advantage of that within their own community is going to really be key to making sure that they have the insurance, they have the backing they need to seek out these services. Okay, thank you. Next slide. So let me tell you about a couple models. I'm going to start with the gold standard, the North Star, what we know succeeds really well, especially with folks that are experiencing serious mental illness or co-occurring disorders. Those populations are those folks that people tend to shy away from because they know it really is challenging to work with them because they are so ill or they really do have a significant needs in terms of the support that they need. One of those models is the ACT model. It's assertive community treatment, and it's really just the gold standard for community behavior health delivery. And the idea is you're taking that whole person and thinking about all of their behavior health needs, all of their physical needs, and bringing those providers directly to that person in the community. A lot of times this starts from the street. ACT teams can start engaging folks as they're living in the streets or if they're living in shelters and start providing those services directly to that individual and then follow them into their unit in supportive housing. And they work very closely with like that housing specialist that I talked about to make sure that that person is receiving those services. It is a team-based approach. And so I'll tell you in one second what that team looks like. Because it really is usually targeted towards folks that are seriously mental ill and those who have really high need. We try to keep the caseload low. So that's when I talked about earlier, referring to that. 1 to 10 is really the ideal caseload, which I know for some of you who are in services is like, but that's really the ideal sense, because these people really do need intensive services. They need a lot of dedication and support. And so making sure that there's 1 FTE that's responsible for 10 tenants is going to ensure that. The other thing is that again, it offers behavioral health directly to folks. And also, a majority of that time is spent in the community. And like I said, that could be escorting them to their appointments, but that also can be meeting them literally where they're at, whether it be on the street or in their own unit. And that's really going to be key. And that's why it is such a great model that a lot of communities have used and infused within their behavioral health systems. Some of them are operated directly out of clinics or behavioral health providers, but really the key there is just making sure that the services are literally coming to that person. And it is the gold standard for chronically homeless, knowing that those are folks that have been living on the streets for a significant amount of time and have some type of disabling condition that but for housing, they're not able to treat and they're not able to address. Okay, next slide, please. And so what does this look like? So the ACT team has, it can vary and it depends, but if you want to keep it to fidelity and make sure you achieve the outcomes that the ACT team is able to, the ACT teams or ACT models are able to achieve, is you want to make sure you have at least some of these core functions or roles within it. And so one is that there's somebody that's a clinician that is able to provide those behavioral services directly. Ideally, it's a psychiatrist and sometimes a licensed social worker. So it's somebody that can do assessments directly. A lot of people who are experiencing homelessness or have cycled in and out of our systems have undiagnosed mental health illnesses. And so being able to have somebody on the team that's right there on the spot that can do that, as well as help them manage their medication, make adjustments as they're observing the person in their own home and seeing that there's changes in behavior that may be linked to that medication, that's going to be key. We have a nurse who's right there that can help them with all of their medical needs, you know, being able to check their blood pressure, being able to check their weight if somebody's struggling with diabetes. A lot of these individuals also have serious medical chronic health conditions. And so having a nurse that's able to provide some of that direct service to that individual is also going to be key. I've stepped on my podium or my soapbox about peer support specialists. And then they also have a general case manager, somebody that's focused on their housing, the housing specialist that does a lot of the work with the landlord engagement, if it's scattered site, or just helping them maintain their rent and all of their utilities. An employment specialist, and then if needed, somebody who has substance use disorder training, somebody who can actually engage somebody around that as well. So that's kind of the key, the core team that really makes up the ACT model. Next slide, please. And on this slide, you can see there's some great praise that goes along with it. As I said, there's a lot of evidence that's out there that shows that it really is successful. They've seen significant reductions in people utilizing our high cost systems, such as emergency services, emergency rooms, cycling in and out of our other institutions, psych hospitalizations, jails, prisons. They've seen a significant reduction in that because of this ACT team model is literally meeting folks where they are and directly providing those services. We've also seen that, you know, one of the things that really makes it work is with this team approach is you have a psychiatrist, you have a nurse that's meeting daily with the case manager and all the other folks that are on the team to check in and see who needs our support today? How is Brooke doing today? How was Brooke yesterday when you saw her? It's a really, really collaborative approach to make sure everybody's well informed. And so really anybody in the team can be tapped into or deployed to meet somebody's needs at any moment because they're so regularly and persistently on contact. Some other common praises too is, like I said, it's got great evidence to show that it works for folks with serious mental illness. And often some states, I know our state does offer ACT team through our state mental health agencies, but also it really can be Medicaid reimbursable. And we just like to highlight that because we just want to highlight that there is significant ongoing funding that can support some of these services if we're able to advocate for it and make sure that folks utilize those abilities or those opportunities. Couldn't think of the word. Okay, so some critiques, some challenges, some things that, you know, are make implementing this model difficult is it is, as you can imagine, expensive. If you think about who makes up that team and the certifications and the skill sets that they bring, you know, those salaries paying for that type of support can be very costly. It is also, if you're operating to fidelity, can be challenging for folks because of those daily team meetings and those high expectations in terms of meeting folks where they're at and keeping a low caseload. It can be challenging. And because of that, we often see some staff turnover, which a lot of us are experiencing anyways in this day and age and as we struggle through the pandemic. But you know, those are some challenges that we have to be honest about. And again, we want to share this and be frank about it, because if you are thinking about adopting this or you want to work with somebody who's implementing an ACT team, you need to be proactive and think about how do you address these challenges ahead of time before they're presented to you. And then last but not least, which is actually very significant and relevant for Nevada, is we have workforce shortages, right? We don't have a slew of psychiatrists that we can hire for multiple ACT teams. We don't have as many behavioral health licensed clinicians in our community that we want. And so I'm a little biased because I also work with our behavioral health policy boards. And so I know that people in our community are actively trying to resolve that and solve that. But again, being able to support that advocacy and that work is going to be important to help our communities bring in models such as this. Okay, next slide. And so because of time, I'm going to skip through this intensive case model really quickly. I will just say that it's kind of the in-between between ACT teams and what I'm going to talk about in a second, which is the tenancy supports model, where it also can be an individual approach, it can be a team approach, but again, the idea is having folks that are skilled and have the licensure, the certifications that are needed to provide services directly, but also making sure you really address these needs for folks. And it's called intensive case management because of that. It's folks that have high need that are going to need some of those services directly delivered to them. And again, making sure the caseloads are small. Okay, so if you can skip past this slide and the next, thank you. Okay, so we want to focus on this one too, because this is a model that you'll probably most likely see in supportive housing, but it's also showing a lot of promise because more and more states are utilizing this model and being able to utilize either a state plan amendment or a waiver within their Medicaid programs to pay for these supports. And so this is tenancy support services. These are those core services that I talked about in the beginning with my little orange circles. That's the focus. The focus is on pre-tenancy, getting somebody housed, tenancy sustaining, making sure they can sustain that housing. So paying their rent, taking care of their illnesses, taking care of their daily living obligations and activities. And then also, making sure that they also are thriving and succeeding in any way that they need. And that's going to be key. And so what's promising about this is, as I said, more and more states are actually utilizing this to support that through Medicaid and other various funding options. But it is also a great way to take a couple steps down from the ACT model, but still provide the quality of services that somebody needs. And so really with this model, the reliance is on making that coordinated effort to connect the tenant with other services and service providers within the community, advocate on that tenant's behalf to make sure they're getting the services and the quality services that they deserve, is really going to be key. If you hear about this model, it's referred to in a lot of different ways. Tenancy support, housing supports. There's a lot of different ways that we can do that, but the key is that it's about housing, keeping somebody housed and providing them those services directly. And so this model, again, doesn't require some of those high cost positions, if you will. It can be somebody that is has a bachelor's degree. They don't even have to have a bachelor's degree to provide these services. It's those soft skills that we know that help somebody connect to an individual, understand their needs, and then make those connections to somebody who does have the ability to prescribe medication or make an actual diagnosis. And so that's really key there for this one, is really making sure that these people are getting these core services, that service coordination is happening, and that, again, making sure that the person stays housed. And on the next slide, just again, to review some of the praise, some of the critiques of it. Again, as I said, the praise of it is that a lot of communities or states are able to leverage their Medicaid SPAs or waivers to be able to make sure that that funding can be supported. It's really promising in that sense too, because traditionally these services are provided by our homeless continuums of care, which are funded through HUD funding. And so recognizing that we don't always get as much funding as we want for those support services, being able to leverage other funding sources to provide those services or even enhance the quality of those services is really key. And so we've seen a lot of success in that in other communities. We always like to highlight Washington State because they've been doing this probably the longest. They've had their program implemented for over 5 years now. They just applied for an extension and they're seeing significant results similar to ACT teams, significant reduction in utilization of emergency services. Tenants are staying housed. They're getting connected to employment specialists, employing and really thriving within their communities. And so that's really important. The downside of it is it doesn't have the evidence-based kind of research and backing that the ACT teams and the ICM models do, because there is variation in how states implement it, because there's variation in how communities leverage COC funds to support these things. And I just told you that it's called several different things. And so being able to narrow down and really get that evidence base to prove that is going to be an ongoing challenge. But as I said, if we look at them independently, we are seeing a lot of communities and programs succeed in that. Okay. And the next slide, please. So with all that, I haven't convinced you that these are worthy things that we should be investing in, that we should be finding ways to make sure that we can bring these quality services to our communities and making sure that they're being offered to folks in supportive housing. We do want to also just highlight that there are, one of the biggest challenges or questions we get is, how do I fund this? How do I support this? And is this sustainable? And the answer is yes. As many of you may be aware, we have a lot of resources that are coming into our communities thanks to the CARES Act, the American Rescue Plan, that really can help sustain and support these types of services to make sure that folks are getting the services they need to stay housed or to obtain and maintain their housing. And so this is just a quick preview of what is actually available currently within most communities that can take advantage of it. As you see, we talk about all different aspects of supportive housing, capital, operating, but that last column is really key there. And so these services, whether it be ACT, ICM, or tenancy support, can absolutely be funded through state budget plans, behavioral health agencies. As I talked about, a lot of HUD funding can also support these services, HOPWA, VASH. You can see that there's several different services that currently are operating within Nevada and supporting that. If you talk to any of them that are doing that work, the question is, the answer you'll always get is yes, it's working, but we need more services. And that's where I'm gonna just pitch the session that we're having tomorrow. Can't have a session yesterday. We're going to have tomorrow where you're going to actually have folks that are doing these services within our state talk about what that looks like for us specifically, and also what are the successes and what are the challenges. And I'm just going to tell you flat out that this is going to be one of them, is they need more resources and support to offer these services and offer them to the quality that they want. And then on the next slide talks about those incoming resources. And I just want to really highlight that a lot of folks are worried about, these fundings being a one-time thing. Are we ever going to see this type of resources come into our community again? It may not, but they can really support some of these immediate needs in terms of getting people housed and supported, but they can also be leveraged to really show long-term sustainability, giving communities the chance to sit back and, like I said, stop thinking from a scarcity model, but think about what is my North Star? What do I really want to do? What's really going to meet the community needs and meet the people that we want to serve, and be able to use this funding to weave in funding to find creative and innovative ways to support those services. So we just really wanted to leave you with that to let you know there's hope. These things can happen, and we absolutely are really excited to see this happen within Nevada. Okay, so without further ado, I'm going to turn it over to what we really wanted to do too was show you what it looks like and have you talk to somebody in a community that's really doing a lot of what I just covered in terms of using some of these evidence-based practices and really, targeting those that are hardest to serve in their community and able to serve them, get innovative with the services that they offer, or the innovative with the resources that they tap into to provide these services to quality that we discussed, and also getting the outcomes that we all want to see. So without further ado, I'm going to turn it over to Joey, he's joining us virtually. So I'll turn it over to you, Joey. Thank you.
All right, thank you, Christine. Hey, so my name is Joey Johns. I work for an agency in Portland, Oregon, called Central City Concern. I'm going to start this off with just, I come from lived experience, right? I've worked in supportive housing for 12 plus years. I've always worked in single site operations, so I don't even know what it would look like not to have supportive housing or not to have single sites to serve our clients in. For many years before coming to Central City Concern, I ran peer delivered services in tandem with supportive housing and in tandem with single sites. And our communities here in Portland are driven with that model to serve that model. The magic, I know for me personally, and I usually don't over disclose, but if I wouldn't have had a peer in my life when I came into supportive housing, if I wouldn't have had somebody that accepted me, I wouldn't have got a college degree, I wouldn't have the job I have today, and I wouldn't be making the positive ripple effect that I am on the community today. Central City Concern, I came to them right around 3 years ago to start up a project called the Blackburn Center, so that he get me trained within the agency. And it was a first of its kind project, I think in the United States, where it was a integrated building where it has behavioral health, substance abuse treatment, pharmacy, recuperative care unit, so people were being diverted from the hospitals, alcohol and drug-free rental housing, alcohol and drug-free programs, all funded by a collaboration of people within Portland, Legacy Health, Kaiser, Multnomah County, the Joint Office of Homelessness. All these people just like band together and got this money to move forward on these services, right? And it was a complete honor to stand this large project up and see the magic that happens in our community around that. But I'll go into that building a little bit more slightly before I go into more of the ACT team model building that we're currently about 85% into lease up. So if you could pull up the slides real quick for me, and then we can pull up some small data off of there. All right, go ahead and skip past this one because that's my little cover sheet. All right, so this data is obviously pulled from last year, right before we got hit with the pandemic. All right, and we have quite a few more units of affordable housing currently, but during that time, 2,136 units of affordable housing, 27 properties. I think roughly we're probably in the 30 properties currently across Portland. In that population, we serve high acute mental health. We serve our BIPOC communities. We serve the opioid epidemic. We serve disabling conditions. We meet them on the ground and treat them like people and give them what they deserve. Everybody deserves housing. Everybody deserves access to healthcare. They deserve access to employment, and they deserve to have hope, right? And in these houseless times, I see such hopelessness everywhere, right? And just a simple thing of like offering somebody a safe place to stay, and letting them know you care about them. It's amazing what that does in somebody's life. So in 2020 we housed 3,944 individuals just in standard housing. We provided safe immediate housing to 141 individuals most vulnerable to living on the streets, just chronic homelessness. And to get into most of our building, what they consider homelessness is like a year of homelessness or more. But most of the people that we're serving, they've been houseless for 5-10 years, living in just tragic conditions, hopeless. It's a sad situation. 407 people re-entering the community after incarcerations. 1,967 people, in early stage recovery or managing their substance abuse. Since I came into Central City Concern, I started off at the Blackburn Center. I opened up a new project, started on it like 6-7 months ago called Cedar Commons. It's just primarily for high acute mental health and disabling conditions. And then recently I just took over all the parole transition programs last month. So all the programs downtown, so multiple buildings down there serving the reentry community from incarceration, jail, and prison. So, it's been an honor to work for this agency. And, every day I go to work, I see hope in the work that they do. Next slide. Some of the things that we do, and this is just supportive housing, right? This doesn't include, and I'll touch basis on it. We serve low income, people recovering from substance abuse, early stage recovery, chronic homelessness, mental health issues, disabling conditions. Program criteria comes from just a wide variety within our agency. We have such a large amount of buildings, a large amount of properties. Primarily we serve low income, zero income individuals. They all have access to Medicaid to get their health needs met. The alcohol and drug free housing that we have, they obviously, if it's a rental house, they do have to have a verification of recovery, because if they're going to go into a rental unit, we want to make sure that they're stable. Otherwise, we're going to place them in another program to help them get stable before entering into a rental unit, right? We want to make sure that they have supportive services. We want to make sure that we wrap our arms around them. We want to make sure that we find them employment, that we have them on medications. We want to make sure that we remove the barriers before we put them into their own housing where they're taking care of themselves, teaching them life skills. Everybody looks at housing like, oh, hey, if we just house this person, right, everything's going to be fine. But that's not the fact. When you have somebody that's been on the street for 5 to 10 years or been underserved their whole life, they don't have the life skills necessary to survive on their own in a rental property. We have a lot of different referral pathways. We work with the Native American Rehabilitation Organization. We work with the Amani Center, which serves just, Black men and women within treatment. We work with the Puentes program, which is our Latinx community, and multiple other referring partners, CODA treatment centers. And we really try to just like engage our whole community. And I'm sure that you've heard this from other speakers in this session, because everything starts within our community and like, how are we investing in our community? Next slide. All right, so models of housing, low barrier housing, we have family housing, alcohol and drug-free housing, housing that just is straight targeted for mental health struggles, housing that, like I talked about with the Blackburn Center Recuperative Care Unit, they are there so that the patients that we're serving in that setting aren't just going to the hospital every week, every other day, because they're in crisis, because they're missing limbs, they're in wheelchairs, they're struggling from substance abuse, just multiple things, right? And so that we just that one program saves the hospital system so much money. Housing that is just for family reunification, housing for people that are just recently employed or working towards self-sufficiency. And a lot of our housing, like our alcohol and drug-free programs, or co-occurring disorder programs, we shift clients that are leaving those programs, and maybe their life skills have improved, they've gained employment, and then we shift them over into our fair market units that are all light tech properties or low income tax properties. Some of the stuff that we do is, most of our staff, not all, but most of our staff have lived experience, right? They've either been incarcerated, they've suffered from substance abuse issues, they've suffered from chronic homelessness in their past, they've, overcame adversity, and a lot of them have overcame that adversity within our programs, and then want to work for us because, our programs assisted them in changing their lives. We have peer support specialists, we have peer case managers, we have CBAs, our front desk staff. They all have lived experience most of the time. Janitorial, our community building associates, which just do the community managers, which just do the property management of our units and our buildings. And most of them have lived experience, not all, but probably 70% or higher. Outreach workers, they go out into the community, especially with some of the housing that we work with ACT teams around, right? Because we have to have people go out in the community and find some of our people that so much need to be housed in order to, one, be able to take medication, two, to even be able to show up for an appointment, right? They just can't show up or become stabilized unless they have a roof over their head, unless they have services offered, and unless they have people helping them. Next slide.
Joey, I'm sorry to interrupt, but for
Yeah.
the sake of time, we wanted to pause just to see if there's any questions. I see that the chat
Totally.
is going active, and I do think people may have more questions. And we only have a couple more minutes left. So
Sounds good.
Is that okay? I'm sorry.
Totally.
Because people will have access to these slides, but I just want to see if there are any questions from the audience, either in person or online audience. I want to make sure we get to address a couple of them at least. No? Okay. Any questions from the audience here?
Okay, hold on 1 second. We're gonna give you the mic. But they can't
This is
hear
why
you.
we're flex.
Actually.
Okay.
So I had a question, because your work is so important for you to be face to face with clients. And
Yeah.
when you talked about the gold standard of 1 to 10, which would be amazing, but
That would be amazing.
during COVID, has it been possible for staff to be face to face with residents at their homes?
Yeah.
as
So
opposed to trying to go virtual? I know a lot of people don't have that connectivity.
yeah. So I'll just touch base on that. So all of my staff are meeting clients face to face. We had to shut down like any large groups that we have to engage in social distancing appropriately. So there are certain groups we segmented off to have small groups for more high acuity clients. And then the individuals that do have access to phones and things like that, we did start up Zoom groups and things of that nature. But all of the staff are still meeting with them every week or daily. They are engaging them. They engage them into their housing units. And, you know, I say this to my boss on a regular basis is like, you know, my supportive housing staff are warriors because they don't care. They show up to work every day, right? And they care about their clients and they care about the people that they serve. And they've been doing that the whole way through the pandemic.
Excellent. Thank you, Joe. You're getting thumbs up from the audience.
All right.
Any other questions? Nothing online. Okay. Nothing. Okay. So okay, we do have a question.
Yeah, and I see that question. So as far as collaborating with the refugee organizations, we are engaging them in Portland. So, you know, there's 3 different ones that we engaged. So the Blackburn Center was actually created so that we could engage refugees. There's a Russian refugee organization that we engage, and then another one that's just standard that serves everybody in the community. And off the top of my head, I can't remember the names because I haven't talked about it in a second, but my staff on a regular basis reach out and get referrals from these organizations.
Thank you. Okay. There's a hand. Hold on.
Hi, my question is for Brooke. I'm Joey Lindstrom with the National Low Income Housing Coalition. My question is about something actually quite small from your presentation, which is about the social impact bonds in Denver and the way they're used to fund supportive housing. Social impact bonds seem great, and I refer people to the Denver example often. But one question I've had, maybe kind of a small concern that I've been wondering about is, because social impact bonds reward agencies for the amount of money that they can save a state on intervention services and so forth, does this incentivize providers to work with the people who are easiest to serve and not the people who need services the most? That's kind of the question I'm always wondering about.
Yeah, it's such a great question. Thank you so much for asking it. And I think, you know, the concept of creaming, you know, is a thing, right? If we, and I think that's the benefit of why coordinated entry was even adopted, right? If we want to address our populations that have the highest acuity, the hardest to serve populations, to get those folks housed quickest, because we know that they're probably most likely to die on the street if we keep them on the street. That is the intent of why I think, you know, if we could have a project that was dedicated to serving that population, you know, and providing the right intervention, the right service model. And I think that was hopefully what was described today around either the assertive acute community treatment model, our intensive case management models, the models that we know are really going to help address the needs of the population that we're trying to serve. Hopefully that removes that notion to try to cream, right? We shouldn't be creaming if we know that we've got the right practitioners, the right type of professionals that are working with our hardest to serve populations. We will see the results. We know that it works. And the social impact bond in Denver, they did work with those hardest to serve populations, and they are seeing those 98% retention rates with those hardest to serve folks. So I really appreciate the question, because it is something that, you know, you would think, yeah, let's just go to where it's easy to get the return on investment, but we really need to make sure we target the hardest to serve. All right, any other questions? All the way in the back. Michelle. She's gonna make you run back there. She just likes to watch me run.
Good afternoon. Referencing back to the beginning of your opening remarks, and you accurately referenced, you know, that we have here in Southern Nevada, we have over 5,000 people experiencing homelessness in any given day, but we only have 5,000 vacant units. in our community. And I also heard you talk about the different housing types for, homeless services. What would you recommend as a CSH employee that we consider in our community for affordable housing and for supportive housing units as we utilize funding that's coming into our community to best utilize those funding and maximize the use so that we can get the biggest bang for our buck.
I really appreciate the question. Thank you so much for asking it. And I think right now we do have a opportunity to leverage resources because a lot of the resources that are coming to our community can fund the capital, the operating, the services that we saw on the screen. And so I think if we could even develop a couple supportive housing projects in our community, leveraging these resources, it'd be amazing if we can demonstrate the same outcomes that they're seeing in other communities like Denver and in our friends over in Central City Concern, the results that they're showing for their community. If we can demonstrate it here in Nevada, right? If we had an opportunity to really provide the right intervention, if we were able to bring partners together, our affordable housing partners that are really important in our community that have been doing a lot of our 60% area median developments and above, if we could sort of help bring those relationships with our service providers that are working really, really hard already doing scattered site, imagine if we can bring those partners together with our affordable housing partners to create a single site, demonstrate that it can work, so we can maybe scale this intervention in our state. I think that would be a great use of funds. And so I did not pay her to ask me that, but I just think it would be awesome to do that.
Any other questions? We actually have a little bit more time than we thought. So I wanted, if there's no other questions here or online, I do want to give it back to Joey. We have 10 more minutes. If there were some outcomes and things that you didn't get to share, I really want to highlight that.
Sounds good. Yeah, go ahead and take the slide back up. So this is just a list of many of our properties. Go ahead and move on to the next slide. So I just wanted to show this part because this just shows like the gravity of the size of our buildings and the amount of people that are served in them. I think roughly the Blackburn Center on my part of it, I'm serving 124 residents, either an SRO structure, which is single room occupancy where they have shared showers, shared kitchens, or in studio apartments. And I think the RCP or the recuperative care unit serves 50 something very vulnerable clients that are accessing healthcare facilities on a daily basis if they're not served. Cedar Commons, which is the newest project that we're just now, I think we're at 90% lease up on it right now. And it's 60 units. It's a harm reduction building. So if clients are engaging in substance use, our goal is to keep them housed no matter what it is, even if they're in crisis, whether they're in mental health crisis. And a majority of the population served there is either BIPOC community and or they have co-occurring disorders. And I'll go into topics around that in a minute. Shayami is another co-occurring disorder building, but it is an alcohol and drug-free facility, and that one's not under me. And I think it is 60 units, all studio apartments that's serving strictly high acute mental health clientele. Next slide. So with Cedar Commons, obviously we don't have a bunch of success rates yet. We're 90% into lease up on it. It is one of the first buildings that we've done in this nature. It's located in Portland, 60 units. 20 of the units are fair market rentals. So we're pulling from all different areas. Many of our BIPOC serving partners within our communities. We have this building on a 2-tier approach system as far as access into the building. So tier 1 providers that get first access, they have to be a BIPOC referent, and they have to be serving clientele with co-occurring disorders. right? So they have to be serving with disabling conditions, mental health, and things of that nature. 30 of the units are funded through Home Forward, long-term subsidy, which pays their rent. If the individual in the building starts working, becomes self-sufficient, pretty soon they get to the point where they're paying 30% of their rent or right under that, because of these vouchers. 10 of the units are what we call choice clientele. So they're the most vulnerable clients in our community. They have, very high acute mental health. They can't retain housing anywhere else. They constantly struggle or accessing unity, chronic mental health care, sometimes suicidal, things of that nature. And they're usually diverting from like the state hospital or correctional institutions. And, the staffing structure at that building, we have a bunch of like CBAs, which just monitor the safety, janitors, maintenance tech that works there, property manager that works there. But as far as like the services team, we have 2 qualified mental health professionals that are on site. We have a case manager that's on site, and then we have a peer support specialist that's on site serving the whole building. And they are all in the same office. They collaborate and they look at everything from a integrated approach and solve problems. And if a client needs to get mental health stability, they get them to get mental health stability, right? And then put them right back into their housing. If they're engaging in substance use, right, we get them over to Hooper Detox or another detox facility, and then get them right back into housing. Our goals are, with our contracts there, are to retain housing for 80% within 6 months, and then 70% within a year. So pretty much our whole target there is how are we keeping them housed, right? We have multiple groups there, community events. Obviously, some of that's a little slowed because COVID. Barbecues, they have like coffee day, movie night, a sense of community. And, one thing I really wanted to touch base on is, just a couple stories of that building, right? So when I first came to Central City Concern, there was a gentleman named James, and I'd go down to Hooper Detox Facility and he'd be sleeping outside with a jacket over him, right? And I served him probably 10 years prior in another program in another agency I worked for, and he wasn't successful, right? And he'd been on the street, I think, for 8 or 9 years, in and out of detox, trying to get help, but a lot of people won't take him due to his high acuity mental health, or he couldn't retain housing because of his substance use. I had his son in another program in prison reentry, and his son wasn't successful and ended up, suffering from a loss of life. And for 2 years, working with CCC, I would see James, multiple times in the community, not doing well, usually sleeping out in the cold. And that, every time I would go up to him and ask him how he was doing and asked him if he remembered me, and he didn't remember me, obviously, due to, extreme trauma, harsh conditions, things of that nature. And every time I would just, tell him, well, I hope that you find the help that you need, right? And all that time I would want to put him somewhere, but due to his ongoing issues, we were having problems finding him suitable housing that would take him. When we started leasing up Cedar Commons, it was one of the first things I thought about, and I contacted Hooper and said, if you see him outside, put a referral in for him. And I think right around 60 days ago or so, I saw his name come up on a list, because most of my job is a lot of meetings, right? And a lot of supervisions and things of that nature. So I don't get the client contact that I used to back in the early years. And I got to see him the first day he moved in, and he got his key, and he hadn't had his own house in many, many years. And on a regular basis, every time I'm there, I see him, and he tells me hi and thanks me, and he's doing well. You know, in another case, there's a lady that we have there named Christine, and when she first came to us, she was really in very high acute mental health distress every day, right? We had to pay for cabs, have staff transporter to get mental health stability, very unhappy accessing the hospitals on a regular basis. And, you know, the last 4 times that I've seen her, right? Every time I talk to her, I'm like, well, how's your day going? And she'll look up at me and smile and say, my day's going well. How is yours? And we'll have like a very short conversation, right? But you know, that short conversation is like an extreme win, right? Because she couldn't even have a short conversation because of the trauma that she's faced throughout her life. She couldn't really communicate appropriately with people, right? And so some of those like interactions that, you know, I have a lot of blessings in my life to see like that magic and that light come on in their eye, or them be able to smile because like somebody cares about them, you know, and that's why I do this work, right? That's why my staff do this work. That's why the community should do this work, right? And it's super important. So as far as success rates with that building, obviously we're not there yet. With the Blackburn Center, tremendous success. Our contracts there are at least 65% exiting to stable housing, 65% exiting employed and self-sufficient. We always beat those numbers, right? And they're doing great. We have usually on average, and part of our contract is that we keep an occupancy rate of 94%. So we constantly are filling the units, making sure people are housed. We have employment specialists that work on site, and they actually cross over and work with people at Cedar Commons to help them with like employment goals, things of that nature. And, you know, throughout our agency, you know, our community invests a ton of money for these type of housing projects because the reality is that they work, right? Right now we're going through a study with an agency called the Bees Team in recovery housing with the Blackburn Center and another program that's called the 8x8 Center. And we're doing a long-term 5-year study, randomized control on actually getting some like hard data on what supportive housing does in our communities, because everybody knows it works here, right? Hence why they invest the money in it. But we're going through this study so we can have that hard data so that they can help the rest of the United States get to that spot, right?
Excellent. Thank you so much, Joey.
Mhm. Yeah.
So I think that brings us to our time. We have 1 minute left. And with that minute, I'm just going to tell you how lucky we are to have Joey here to share that, because they really are having great success. And we just really wanted to lift that up to show that it can work. And the only difference, as Joey illustrated, is, you know, they've invested in it and they've lived to the fidelity, and they've made sure they really support the tenants and meet them where they're at. That's the only difference between what they're doing and what we can do in Nevada. And so I hope you walk away with that hope and that motivation to really advocate and continue to do all the work that you're already doing to make sure that we can see the same successes that Oregon is seeing in terms of housing those really challenging individuals who are really, really in need of support, and being able to have stories like Christine that we can share across our communities.